sessions are also recorded by,
Yes.
it is recorded by you?
Yes, sir. So now we are live and the sessions is recorded. Yeah.
Okay, fine.
And we have participants join.
Okay.
Because you may change Dr. Karthik's name, it is appearing now.
Yep.
Karthik, how are you? You are also having fever, you just told me.
I just removed my mask and I think I should survive the webinar. Hello to everybody. Good evening. Good evening, Brian, and nice to see you after a long time, Praveen.
Hey, Karthik. Nice to see you as well.
The beard is new.
And the beard is new. Something had to change. And also the gray hairs, if you noticed. Yeah.
And you picked up an accent very fast.
Oh, yeah, that's true. When you walk like a Roman.
So you're there full time, or are you shuttling between Kerala and UK?
No, it's yeah, I've been right now for the last 2 years. Yes, it's a full-time engagement. It's been full-time and kind of liking it. But missing you guys, missing the pain.
We miss you too, Praveen.
Yeah, honestly, it's great learning, great things which you can do for patients as a pain clinician. And
so most of the audience would be more interventional folks, or
Most of the audience will be like that. But from other Kamlesh, can you tell what are the, from our side, most of them are the pain physicians, interventional pain physicians.
Yes,
but
yes.
we other GPCPs are also there, isn't it?
It is there. They are also interested for head pain and face pain. So it's a mixed audience. Only physicians as well as pain specialists. Two groups will be there.
So I picked a presentation which I hope will be palatable to a broad audience. A clinical talk on mid-face pain in particular.
Right. I hope we'll be focusing more on diagnosis, isn't it?
Yes, actually, yes.
Okay.
In particular, yeah.
So, Kamalesh, you can tell when should you start?
It's 7, sir. So you can take over the sessions. Because can you make Dr. Gautam?
Yes, sir. Already made.
Yeah. So you can start.
Okay. Thank you, everybody, and welcome you all to this session. Headache is one of the very, very important area, and we know that as a pain physician, this is one of the common area, maybe first or maybe second to the low back pain, why a patient come to at least a pain clinic. Many of the headache patients goes directly to the neurologist, that is true, but some of them are coming to a pain physicians as well. And what we feel that a ideal management of headache should be done by a team where there should be neurologists, where there should be neurosurgeons, where there should be interventional pain physicians, all together should be able to manage the patient nicely. And of course, very important role of the general physicians are also there, because they are the first contact with the patient and a doctor. And they should be, identifying the basic things, and they should be thinking that it should be a team or who can better manage it. So the role of diagnosis is very important, and I hope Dr. Bayan will be taking these very important areas, midfacial pain, as well as there will be one very important case by Dr. Javed, and we'll be discussing what are the different possibilities and how to manage. So before we start the session, Dr. Karthik will be the moderator about the whole sessions, taking the charge. But before that, I'll be inviting Dr. Praveen. We are, he is doing very nice right now, settled in UK. But we are proud that he was, he started his at least pain part from us from Neuralgia. So we are very proud of you, Praveen. So I'll be asking Praveen to tell, that they have formed the World Headache Society. I'll be asking him to talk a few words about its activities, its mission, about the World Headache Society. And then I'll be asking Karthik to take over and to start the session. Dr. Praveen, please.
Thank you very much, sir. And as you said rightly, I've been a proud product of Neuralgia Pain Clinic and of yourself. Foundations of pain medicine have been set by you, and it stays quite strong, I believe. Probably the patient is to judge that, but yes, personally, I feel that they're quite solid even now. Thank you. And let me just share my screen if you don't mind. What I just wanted to show you is a very short presentation on the society. Are you able to see the screen?
Yes, Praveen, go ahead.
Lovely, thank you. So the World Headache Society is a global headache society, as the name suggests. And the aim is to empower health professionals and patients in countries which are historically underrepresented and or underprivileged. And the field of view is scientifically is inclusive and worldwide, and sort of activities are focused and tailored towards these regions in Asia, in Africa, Central and Eastern Europe, and Middle East, and Middle and South America, and Central America. Now, as a community, we wish to nurture headache science worldwide, incorporate cultural intelligence in headache science, provide education for all qualified and licensed medical practitioners in the art and science of headache medicine, create credentials that recognize a specialism in headache medicine, enable knowledge sharing and community creation, promote the integration of physical, mental, social, and spiritual health, and empower patients through education, confidence building, and advocacy. Now, what makes us slightly different, or probably grossly different, our priorities are progress and not profit. We have a policy of no pharma funding. To retain our impartiality, our focus is on cultural intelligence and a holistic approach to health. We want to reach all practitioners that see and treat headaches, and not just a group of specialists in neurology and neuroscience. Our focus is on patient education and empowerment as well, and on creating recognizable credentials for headache medicine. Now, how do we achieve this? We have a geographical network of professional chapters, currently 80 chapters, and there is a distance education and skill-based training. We are running a course. We have virtual peer groups. We encourage networking, mentoring of future headache specialists, conduct symposiums. We have a journal. We are really fortunate to have today's valuable speaker, Dr. Brian, as its editor-in-chief. And we also have a magazine, and we have a presence in social media. So the ways in which you can get involved with the World Headache Society is to participate in the one-year course that we're offering, which covers the whole of entire headache medicine, with weekly webinars, quizzes, and an exam proctored. You can join as an individual member. You can join or start a chapter of the society in your region and volunteer with us to help grow the society. You can join as teaching assistants, find us on social media, and help spread the word. And then tell the colleagues and patients about it. These are the ways in which you can help us grow. And I think that's this is what I just wanted to just mention. And thank you, Dr. Gautam Das, sir, for giving this opportunity to introduce the society to this wonderful audience here. And I look forward to more learning and more teaching in headache and neurology. Thank you very much. Thank you, Karthik.
Yes, thank you, Dr. Praveen. And I'll be asking now Karthik to take over and invite the speakers as well as the other panelists and continue the session. Karthik, please.
Thank you, Dasar and Praveen, for the introduction of the society. So it's my privilege to introduce Dr. Brian McGinney. He's an associate professor in neurology in John R. Graham Headache Center, Brigham and Women's Faulkner Hospital. Boards in neurology, board qualified in pain medicine, UCNS, board certified in Headache Society. I've got a whole list of qualifications and achievements by Dr. Brian McGinney, and I can vouch for it and say that he's an authority in headache. So let me have the pleasure of inviting Dr. Brian McGinney to talk about midfacial pain. Dr. McGinney, please.
Thank you very much for your kind introduction and your kind invitation. I'm going to share my screen right now. And just let me know if for some reason you don't see that. I grew up and got my medical degree in Europe, in Dublin, Ireland, and I've spent over 25 years in the United States. Most of that was spent actually at the City Hospital in Boston as part of Boston University Medical Center, although I've moved now and just across the street or thereabouts. And delighted to talk to you about this interesting topic. And the reason, one of the reasons why I'm so interested in it is many specialists have a stake in midface pain, and it's a bit of an enigma for many specialists. And so I wanted to just do a little clinical talk of how one tries to piece apart the various diagnoses that go into a midface predominant pain, as opposed to primarily a headache or even a one-sided pain, more either exclusively or mostly midface. And to remind ourselves that this in the sensory homunculus in the brain, 50% of it or thereabouts, it represents orofacial sensation. So it's vastly overrepresented in the sensory homunculus, as described properly by the late Wilder Penfield, a Canadian neurologist. And so hypothesizing that then maybe the consequences of injury to the trigeminal nerve will be greater or much greater than other nerves. Now, fundamentally, so who lives in midface? Well, the dental live in midface, ENT, mostly rhinogenic. That's me, in neurology diagnoses, and other. And I'm going to populate it with some. That's not the complete list, but it's partial. And we're going to go look into some of the more common diagnoses or commonly misunderstood diagnoses. We're all familiar with how the trigeminal nerve innervates the face, and even most of the head, and most of the intracranial structures, but not all. And the clinicians will know that one of the tests, if you're concerned about a peripheral nerve injury involving the trigeminal or not, is the trigeminal does not innervate the skin over the angle of the jaw. So if a patient has sensory loss there, not radiating sensation, but sensory loss, one has to think that it's not a trigeminal nerve injury. Either it's other peripheral nerves or more central. And to look a little deeper, here are some of the common nerves that we go after, even with local anesthetic and occasionally steroids. Midface, of course, is a little different. We don't have quite so many nerves. Infraorbital nerve is sometimes targeted. And I put, because they're so common, the occipital nerves commonly blocked in somebody with headache or neck pain, occipital pain. Now, but what about nerves of the midface? Well, here we have the maxillary nerve, and we see contributing to the sphenopalatine ganglion, separated only by mucosa from the nasal lumen. Hence, many of the sphenopalatine blocks utilize that access. So without puncturing mucosa or anything else for that matter, you can introduce and diffuse local anesthetic to the nearby sphenopalatine ganglion. And this area anatomically has been an area where even sphenopalatine stimulators have been bolted on. Some of you may be familiar with a couple of trials over the last few years, but it's not without its problems. You'll see the alveolar nerves, and I have seen patients where the well-meaning implant to stimulate the sphenopalatine ganglion has bolted through an alveolar nerve, leaving the patient with chronic sensory loss and, more importantly, pain for rather a long time, unfortunately. Here we have the infraorbital nerve. I'm going to touch on that a little later. We see that commonly involved in facial trauma, and it's also in bony disease, easily involved, causing local sensory loss. It's usually quite easy to make that diagnosis. And just so we know, the cranial nerve innervation, and this can radiate and refer discomfort and sensory symptoms, not just to V1, but also to midface. Most of the intracranial structures are innervated by branches of V1, ophthalmic division, trigeminal, but we do have other nerves, the upper cervical, a little bit. And more importantly, we have a representation from V2 and V3 innervating the meninges, so easy to refer discomfort to the face, not just V1, but V2 and V3 also. So back to our differential. Dental, anybody in pain management has to know something about dental pain. And we're all familiar with the pulpal pain, the terrible dental pain that most people have got at some stage in their life. And it's, how do you know when kind of mouth pain, dental, it's really dental or not? Well, there are a couple of features. Of course, if there's a tremendous hot-cold sensitivity, it can give the game away for pulpal pain. One of the characteristics of pulp pain is it's poorly localized. So most of us have had the experience of a dental pain, but weren't quite sure, not even white tooth, but whether it was upper or lower jaw. That's pulpal. Once it involves the soft tissue, such as the apical area under the roots, that's extremely well localized. There's no problem finding that. It's often tender as well. If pain is bilateral, it's not odontogenic, typically. Apart from pulp, the ligaments around the tooth can be painful as well. Even attempting to move the tooth gradually with braces or suddenly, and that can also be the result of pain when the tooth itself is intact. Now, non-odontogenic pain is also common. It can be muscular or joint-based. Myofascial pain is a topic that's talked a lot by dentists who specialize in facial pain, but not anybody else. But it is actually quite common. A lot of people with malocclusion and can be associated with a lot of muscular pain. But in the neurology world, we don't really recognize that so much, unfortunately. And of course, the term TMJ has a world of its own. Here are some old and famous Travell and Simmons images on referred pain from muscles. There's the masseter. And one of the most, I think, impressive outcomes I've seen, purely anecdotal, is botulinum toxin injected into muscles of mastication and those who grind teeth, and that may contribute to their headache disorder. Here are some referred, so injected into the muscle and referred discomfort. That's the masseters, and there's the pterygoids referring to this area of the face, mid-face. So in the dental world, quite a common cause. Now, ENT, and most of the ENT causes would be rhinogenic. And here we have the nasal sinuses that we're all familiar with, 4 of them, including, don't forget, the sphenoid sinus. It can be a little problematic if you get infection which bursts through, because you can burst through into the CSF. And I've seen that happen. Although mostly we see infection and symptomatic of maxillary or frontal. And doing a lot of head imaging, we see retained cysts or fluid levels extremely commonly. and it only poorly correlates with symptoms. Old Harold Wolf studies, this goes back 50 years, more 60, 70 years, where stimulation of the turbinates in the nose and where the discomfort was felt on the face. So that's on the face, and also stimulating turbinates where it was referred to dental pain. So you can get dental pain from nasal sinus pathology. There were other studies clearly demonstrating that it's really the ostia of the maxillary sinuses, or of the sinuses in general, which are most sensitive. And our intrepid investigator, Dr. Wolf, even put what looked like a glorified Foley catheter balloon up the maxillary sinus and started to blow it up. He put it through a fistula in a patient, and he had to get to 200 millimeters of mercury before there was any pain. And it turns out the mucosa is not well innervated by pain receptors, but the ostia, entry-exit points, are. And the rhinologist will tell you that most patients with purulent secretions, even on endoscopy, do not have facial pain, funnily enough. And most pain seen by rhinologists is not due to sinusitis. And there's an argument over how much, if any, facial pain is caused by chronic rhinosinusitis. It was the rage about 10 years ago to talk about contact point headache. And by that, they mean structures in the nasal cavity that meet, for instance, the deviated nasal septum and its adjacent wall, and remain in contact after a decongestant. And there were some positive case reports and case series of surgery and people doing better and attributing the headache to this. It was a bit of an enigma, but in the end, it doesn't appear to hold water, so to speak. The reference is of nearly 1,000 patients, consecutive patients at a rhinology clinic. I hear there's a bit of noise coming in. Oh, that's finished. So this patient, this publication, nearly 1,000 patients in a rhinology clinic, divided into those with pain and without pain, who happened to be referred for a CT scan. And it turns out that the prevalence of contact points at about 4% was the same in those with pain as without pain. And if you looked at those who had one-sided pain and those who had contact points, 50% of the time the contact point was on the other side. So to me, there is no good evidence that contact points cause headache. A little bit anatomical lesson. I mentioned the infraorbital nerve and how it pops out in mid-face, but it runs adjacent the maxillary sinus. But if you're unlucky, it actually traverses a little sinus lumen that descends into the roof of the maxillary sinus. And that's fine, unless some well-meaning ENT goes in to scoop out your maxillary sinus. Now, most folks, of course, know about this and can see it beforehand on CAT scan or intraoperatively, but it's another cause of some sensory loss and facial pain post-procedure. This is an intriguing case. I'm going to show you this. And it's intriguing because either you know about it or you're lost at sea. This man, I saw this man in February of 2019, 48-year-old man. He was so-called second opinion. He'd seen multiple ENT, dental facial pain experts, and was sent by another neurologist. Now, lots of diagnoses, including the correct one, were considered. But there were, for some reason, there was uncertainty as to what was going on. This man had a normal cervical fusion just about 3 months before that, had a post-op infection, did fine, discharged, healing normally. And then in the middle of December 15, he woke up with an aching pain on the left side of his cheek. For a few hours, constant, went away. I mentioned that he used CPAP. It's not really relevant. Pain recurred 2 days later and continues. The history gives you the diagnosis. And if you ask about the history, it's left cheek in the region of the parotid gland. And he said that when he starts to eat, he gets severe pain for a few seconds only, and then that dies down, and he can eat. And if he stops eating and he starts to eat again, the same thing happens. And that was going on for weeks and weeks and weeks every day. Notice key points. It's pain in and around the parotid gland. Now, he had seen ENTs. There are no stones. The parotid ducts are intact. There is no blockage. And there is no apparent nerve injury. There's no sensory loss. And that was the story. And importantly, if he had the aroma of food, that could trigger pain with salivation. And the other way to do it is to squirt lemon juice in the mouth. Again, pain. So what gives you pain in a parotid, in a parent with saliva production, but there is no blockage? And either you know this or you don't. And it's first bite syndrome. It's a bit of an enigma. This syndrome, that's the history for the syndrome. And we think that if you recall, the salivary glands has contractile elements, muscle cells that contract and expel saliva. But if they overcontract due to what we feel, the best guess is an autonomic disruption, so an autonomic imbalance, more spasm of those muscles, and that will cause pain. And it's been associated with surgeries or procedures of the head and neck. It generally does go away. It taking weeks to months completely. The treatment, the only treatment, I think that makes sense, and would be a little bit of botulinum toxin to reduce the spasm. Anyway, so all right. So what about neurology and facial pain from stroke? Well, one of the when you see somebody and you're concerned about stroke, I like to hear a pain symptom because I know it's likely not stroke, because it's pretty uncommon for stroke to present with pain. However, there are exceptions, and one of the exceptions is facial pain. And it's well described that those who have a ischemic stroke of the bottom of the brainstem, that's the medulla, lateral medullary syndrome, or the pons, mid-brainstem, can present with discomfort and pain in the face. And this is not a delayed thalamic central pain syndrome sort of present. It's more of an acute pain. And a central pain is generally much more diffuse. A central pain, the more classically, that is classically described. So here we have the lateral medullary infarct, Wallenberg syndrome, which can be associated with spinothalamic or pain and temperature loss on one side of the face, but can also be associated in particular, and of note, of a tingling, discomfort, dysesthesia of the face. When of these patients, the pain intensity and disturbance is low, so it's not a severe pain. So the patients can generally go about their daily activities. And here we have some case reports involving a pontine infarction and discomfort. Now, primary headache disorders, we typically think that they're bilateral or one-sided, and they can be, or around the eye often. They can also involve heavily the midface. Generally, the diagnosis is not in question. However, for a small number of people, you will get a predominant midface presentation, and that will certainly induce chaos with respect to getting the correct diagnosis. And the way you go finding these patients is they wash up in ENT clinics and rhinology clinics, and screening their literature, a small number of people, and I've seen it myself, certainly are more mid-face migraine patients. I use the term mid-face migraine, but it's not really in the literature. And don't forget cluster. Cluster is worst around the eye and V1, but especially initially when the patient is presenting first, they may talk a lot about pain in the teeth, in the jaw, in the neck. And some continue to do that. And it's important to focus on where the worst pain is. And the patients, their narrative may include a lot of mid-face pain as well, unfortunately. The giveaway over 90% of the time is a rather obvious autonomic features with the pain attacks, and the pain attacks are short-lived. The severe pain is only an hour or two, typically. One of the key reasons why you could separate pulp pain from the other severe facial pain syndromes is pulp dental pain is not severe for weeks and weeks and weeks and weeks and weeks. You can have severe dental pain from pulp disease for days, but not weeks and weeks and weeks. That's neuropathic. Another paper looking at lower half facial migraine in a dental clinic and screening many patients. They found 10 women, 1 man, and of course migraine being more common in women. And what else is there? So there is the neuralgias. Now, I live in a world where it's very easy to term any facial pain as trigeminal neuralgia, which is of course not the case. And what about dividing it up into classic trigeminal neuralgia, where you can demonstrate a compression by an artery causing deformation of the nerve? That to this day is classic TN. However, there's plenty of TN with no compressive lesion because the problem is a focal demyelination ultimately. But there's also plenty of other facial pain, and be careful about using the term TN. You can use the term, and I use the term pain in the distribution of the trigeminal nerve until you have a better diagnosis. Or if it's traumatic or you know the diagnosis painful trigeminal neuropathy, separating it from TN. And the proper way to kind of classify it is probably the classic TN with the demonstrable, not that there's a vessel near, or even that there's a vessel lying on the trigeminal nerve. It has to be deforming it. It's really only the cases where there's deformation that do best with a classic surgical decompression. And then if it sounds exactly like TN, but no compressed vessel, it's idiopathic. And if you have a demonstrable lesion, other lesions such as a mass lesion, the most common lesions would be a CP angle lesion, meningioma, and multiple sclerosis lesion at the root of the nerve. So it's a CNS lesion, can also give you identical trigeminal neuralgia. That's to remind me to say neuralgia in the distribution of the trigeminal nerve. And for those, I'm sure you're all very familiar with TN. This is a lower 2/3 face problem, mainly. It gets a lot more complicated if you're to implicate this in involvement of the upper third. The upper third pain can often cause unilateral autonomic features anyway, which can confuse the diagnosis. Often there are trigger points on the face which will trigger the attack, and also giveaways include that when the TN is bad, the patient doesn't even want to speak, is trying not to move their mouth, eating is difficult or triggers the pain, makes it worse. If you have multiple sclerosis, you have about a 4%, even 5% lifetime risk of TN, and even bilateral TN. But the great majority of patients with TN do not have MS. And I would be careful about subjecting the MS population to surgery for TN, but they are amenable to the interventional procedures. And I think, do I have any? Okay. The procedures for TN are, of course, in summary, while under a general anesthetic, the introduction of a balloon into the region of the ganglion and blowing that up, and the patient is left with some numbness of the face, but the reduction in sensory input tends to switch off the TN. I like that procedure a lot because it seems to me is the most benign. You can also use heat with a nerve again. Patient is generally under a general anesthetic, or directed radiation, the gamma knife. So there is no needle and the patient is awake, but the outcome is delayed. And of course, those are particularly suited when you don't demonstrate a clear compressive lesion of the trigeminal nerve, because again, the problem is a focal demyelination at the border zone between central and peripheral myelination. And that's ultimately the problem, and whether you got that way due to a compressive artery or not. So painful trigeminal neuropathy. So that would include all the postherpetic zoster and facial trauma. Here we have shingles, zoster, and this is like an advert to get the shingles booster vaccine. The first vaccine to come out reduce your chance of experiencing shingles by 50%, but the later one is a 95% reduction, which is great. And the diagnostic dilemma is often until the rash is seen and the patient has severe facial pain and nothing to show for it. And of course, they're not going to get very far in an emergency room without anything to show for it until the rash appears. It's useful to think about. Again, you're looking for a few days of pain, maybe a week at most, before rash. And how many patients never get a rash? We don't know. We don't have data to really know about that. But unfortunately, unless you have a rash, you generally are not going to be treated as zoster, even if you suspect it. And glossopharyngeal neuralgia, another neuralgia, it's considerably less common than TN, pain at the base of the tongue, mouth, or throat, paroxysms again, and nervus intermedius. So this is the ear pain. Nervus intermedius supplies a sensory part of the ear. And one can imagine that paroxysm will then give you paroxysms of pain in the region of the ear. And theoretically, we think that that nerve, again, may be subject to compression by external structures, but maybe also a focal demyelination may be responsible largely. And so here we have the differential that I ran through. I think I have a few more to go. I'm this lady I saw a few years ago, not the greatest historian, said she was a nursing home resident, says she was eating and then developed sudden sharp pains on the right side of her mouth, and sounds very like TN. And we saw her question about whether some area was tender in their mouth. If you're not certain about a focal area of tenderness in the mouth, it's a red herring. It may be referred pain. So she went to dental or oromaxillary surgery. They didn't think there was anything wrong there, so she got scanned. And here we have a CP angle mass, quite a large one. I think I have a video just to show that this is here's the mass, CP angle mass. All right. So CP angle masses can easily cause somebody's very noisy facial pain, and you may or may not have any sensory loss, and you may or may not have involvement of nearby cranial nerves, such as facial weakness. Intrathoracic origins of pain. I thought this is fascinating, but it's been 20 years since I've seen patients with, say, lung cancer present with facial pain where it's not metastatic, and theoretically possibly involvement of the vagal nerve may give you facial pain, unilateral facial pain. And then cardiac ischemia is the other example that people tend to talk about, and that more commonly can give you neck pain, lower jaw pain. Through the years, there have been a couple of patients with fibrous dysplasia of the meniscus. This is a bony disease where normal bone is replaced by a softer, abnormal fibroosseous tissue, which causes distortion and there's overgrowth. And it's really quite a terrible disorder in the facial bones. And you end up with repeated operations, and there's often a pain problem. And this sort of growth kind of crunches the inferior orbital nerve. Many nerves are often involved, encroached and there's not a lot one can do. And true to form, the neurologists in their classification and the international classification of headache.
COVID-19 vaccine by Novavax, a small U.S. company that has never before brought a product to the market, is preparing to file a request for U.S. authorization.
Not sure whether that's me or not.
Vaccine to be.
And finally, there is a true to form neurology has a wastebasket term, the persistent idiopathic facial pain. And that's not well defined and really used as I don't know what else is going on. I'm not sure what's going on. Throw it into that. It really needs a better definition. And sometimes better terms include painful post-traumatic trigeminal neuropathy when there's been trauma. Anyway, I have plenty of time, I understand, so we can talk and take questions on this topic of mid-face pain in particular. Thank you, folks.
Thank you, Brian. I guess doing justice to midfacial pain in 30 minutes is going to be tough, but you did touch upon majority of the relevant topics. Thank you, Brian. Do we have any questions for Professor McGinney? I saw one on how you sort of collaborate with dentists in terms of dental surgeons if you do see midfacial pain.
Well, you have to have a relationship. You have to know who's available and who's interested. You see, I have found that most dentists are not that interested in persistent pain and facial pain, and it can be quite difficult to identify folks who are interested. Now, I'm lucky in that I do have some resources available to me, and there are a number of centers in the city that I work in, which helps enormously. And so the answer is you have to firstly identify who's interested, which of the dental, because it's not, it's a challenging, pain itself is challenging, and dental pain, facial pain, it's a challenging clinical problem that may not be, there are far easier paths to go if you're a dentist than that. So just make your connections so you can create a relationship. That's what I would say.
Right. Okay.
And Dr. Dasya, Brian, can I ask you another very important, your experience regarding, how often this facial pain is because of the, sinuses or from the, eye causes?
I want to repeat your question.
How often?
How often is it due to the nasal sinuses?
How often? Sinusitis is the how often? I am asking about
not often.
Amongst the everything almost.
Dr. Das, because of there was a bit of a sound breakdown, can I ask you to repeat? What I heard was how often is facial pain due to nasal sinuses? Is that? I think you might have frozen.
Yeah, I think that's what he asked.
Yeah. And the answer is less than you might think, not often. When patients have mid-face pain, they think sinuses, 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 sinuses. That's what patients think with mid-face pain, because that's all they know, or possibly dental. And of course, if it's bilateral, it's not dental. And a lot of the times it's bilateral. But as I was saying, Dr. Das, patients think sinus, sinus, sinus from mid-face. That's what they know.
Right. And it's very, very commonly they ask, and they ask and they tell this question, okay, I am having the sinusitis and that is why I am having pain. Sometimes, the patients themselves becoming doctor, and they themselves tell their diagnosis that probably it's a sinusitis. It is quite common.
I find myself explaining to patients that I'm interested in your symptoms, not your diagnoses for now. I will ask you what you think is going on, but otherwise you have an extra step to do as a clinician, and that is to backpedal out of their diagnoses and into their symptoms. And that's an extra step for clinicians. So I explain to patients, I want to know your symptoms, not your diagnoses, as a way. And they're just trying to be helpful to you. But yes, it's extremely common for patients to diagnose themselves with sinus disease. And the ENT folks are deluged by patients with pain who do not have an ENT problem. Most commonly migraine, admittedly, but absolutely deluged. And so that's
And another common thing, Brian, is your, the pain around the eye and the headache. Again, that most commonly they think that this is the change of the powers. Refractive errors is the commonest cause. This is the
they commonly think it's what? They commonly think it's what?
Refractory errors.
I'm sorry?
Refractory errors.
Your refractive problem. Yes, totally. That's a very good, yes. Well, you see, yeah, because of course, so much of V1 refers to the eye. And the thinking is maybe there has to be an eye problem then. And what does the eye do? And well, maybe it's not focusing like it should and getting the refraction checked. And that, I'm not so sure that refraction problems has ever been the cause of bad headache. I mean, you can sit on the fence about milder headache, but not bad headache. I'm not sure it's ever been.
Right.
But it's commonly done. And of course, what's in vogue now over here is to get the blue filtering lenses, or getting that added to whatever you have, and those with headache disorders, to knock out the blue light in particular. But that's true.
Yeah, thank you, Brian. Can you throw some more light on greater auricular nerve pain? Greater auricular nerve pain.
Yeah. Yes, greater auricular nerve pain. Of course, we block that nerve a lot in headache medicine, because when for primary headache disorders, and when we want to block, we block not just occipital, we want to block greater auricular, preauricular, and even supraorbital. So we do a lot of blocks of that nerve, but 99% of the time, the patient has primary headache, but doesn't have a neuralgia. Now, I'm getting flashbacks of the rare patient who post neck dissection ended up with neuralgia. And I've seen it specifically in that case. But otherwise, it's difficult to conceptualize how you could get a neuralgia from a superficial nerve when it's not entrapped. It can get entrapped in scar and post-surgery. But as I'm answering your question, those are the only times I've specifically seen auricular.
So when you say block, you do a diagnostic and then you do a radio frequency ablation of the nerve.
Oh no. When I do most of the blocks that I would do for auricular and auriculotemporal nerves would be in connection with blocking all around for primary headache. Occipital, greater, lesser, auriculotemporal, supraorbitals. So this is, and mostly I just do local anesthetic. And what I'm trying to do is, and typically the patient is a chronic migrainer and has been through many medications, and it's a medication sparing management. And so I'm not attempting any destructive at all, because the problem isn't there. We're trying to reduce the sensory input and nociception for a while. And Again,
but how long is the benefits are going to last?
right. The reason why one does a procedure like that, as with many procedures, is you want to reset the system. You want to, with bupivacaine, of course, within some hours, 4 or 5 hours, it's back to normal. That's not why you do it. And you don't do it just to get rid of pain for a few hours. You're doing it so that when that wears off, you hope that the amount of discomfort the patient will be left with will be less. And that's not uncommonly the case. It's quite intriguing, and especially when you throw in trigger points to the muscles. Those who have chronic headache often have chronic neck pain and myofascial pain. And when you also introduce that, when that's all blocked up and numbed up for a while, as it wears off, a proportion of the patients are not back to where they started. They're at an improved place, and that's why you do it.
So basically, it's breaking the pain cycle. So it can be having the long-term benefits than the local anesthetic duration of the the pain relief.
Yes, yeah. You're doing it for a benefit theoretically that would last far beyond. And then the patient will tell you it's either yay or nay.
Right.
Right, Brian. Thank you very much. One final question. Considering that most of the audience are not neurologists, most of the audience are interventional pain guys. For midfacial pain, what would be your radiological imaging of choice?
Good question. Well, at radiologic imaging of choice, I would still say MRI because it's no radiation, unlike CAT scan. And you get good visualization of the nasal sinuses. Admittedly, the CAT scan has the benefit of looking at the bony structures in greater detail. I mean, I'm biased to MR because I'm a neurologist, but you ask the same question to an orofacial pain expert who's a dentist, and they're going to say CAT scan because they can, and an ENT will probably say CAT scan because they can assess in detail the bony structure of the sinuses. However, with the MR, you're also getting good detail further back behind. You can get the whole brain done as well and get a shot of the brain. So a CAT scan, a bony CAT scan is excellent. I have my biases again to MR because at least in a younger person in particular, you want to be shy about giving CAT scan radiation. An older person doesn't matter so much.
Okay, thank you, Brian. We'll take your word for it. Thank you. Is there any other questions for Professor Nagini? I think we pretty much covered whatever came up in the Q&A. Just one more. Eagle syndrome, elongated styloid process.
Well, there's an argument over whether that exists at all. There are folks in the business who say it doesn't really exist. And so I still feel it's controversial. I certainly have seen, but I have never sent patient for that surgery, but I have seen patients who've had that surgery. And I think we've got to be careful not to take advantage of the patient's desperation and those with headache and facial. Fortunately, with that syndrome, most patients who have chronic facial pain have bilateral facial pain. So they can't be persuaded they have Eagle syndrome. You think if they're going to have elongated process, it's only one that's going. See, it's a unilateral syndrome. I'm somewhat skeptical that the entity really exists.
Okay, and just the questions keep coming up. Somebody's asked me about how often you use botulinum toxin.
How often? How often do I Botox? Well, let me tell you, those who know me know I'm a big critic of its use in chronic migraine. Well, when I say but I like to get the indication because then it's the only way I can get insurance to cover it, and then I can use it for those who are grinders, and that the outcomes I think are tremendous when you have people who are grinders, and we think contributes in some manner to existing headache disorders. So I use botulinum toxin quite frequently in chronic migraine because patients request it. The reason I'm skeptical is the data. There are about 17 randomized controlled trials, nearly all negative. I mean, the first one was positive at 75 units and not at a higher. It was very unimpressive. And the two preempt studies that enabled a chronic migraine indication, the difference is small and is better accounted for by reasons other than a true effect, i.e. incomplete blinding, where pain studies are handicapped big time by incomplete blinding. Then your outcomes are driven by expectations and conditioning. So we fool ourselves with our clinical studies many times. And the solution to that is to show that the patient is to test your blind, because otherwise you can analyze based on perceived assignment, and you actually get different outcomes. So how often do I use botulinum toxin? I use it mostly for chronic migraine because I'm a neurologist, headache medicine. I love to use it in the masseters and people so affected, as mentioned. But other than that, I really and then it's just occasionally somebody who has hemifacial spasm. But from a pain point of view, it's difficult to get it covered, and it's expensive if you're attempting to do myofascial injection in the head. Even if you want to inject the neck, in my practice, I try and get a chronic migraine indication, which would be the only way it would be covered by insurance where I practice.
So in your practice, for chronic migraine, Botox injections are covered in spite of the duration of the efficacy?
The sound broke up.
4 to 6 months or something.
So I understand. I lost some of your question. I heard about the Botox chronic migraine, but the question was lost. Just the sound dropped. Can you repeat?
The Botox is going to work for 4 to 6 months, something like that, right? So in spite of it, insurance is providing?
So the botulinum toxin, we think of it working for 3 months per injection. So typically when you use botulinum, and now there's to justify the use in chronic migraine, there are theories about its action at nerves, because it's an excellent antispasm agent, no question. It has multiple indications here in the United States by the FDA as an antispasm. It works wonderfully. It just doesn't for chronic migraine. And there is a rationale based on its direct effect on nerves, which is really highly skeptical and theoretical. There is no numbness. And botulinum toxin is taken up by the nerves and can be demonstrated to exist in areas quite distant. It's a very potent neurotoxin. But the rationale for use in headache, its effect on nerves, is unimpressive to me, highly skeptical. Whereas there are many other agents with better evidence-based medicine. However, botulinum toxin in the United States anyway, there's a chic kind of exclusivity, cosmetic element, and then direct-to-patient advertising. And before you know it, it has a momentum on its own that it won't be taken down by lack of evidence.
Right. Thank you, Brian. Thank you for the excellent lecture and answering all our questions patiently. Thank you very much.
Thank you.
Okay, Brian, you stay there to have the discussion about the next case.
Yep. I'm going to stay here.
Yes.
Thank you very much. Can I invite Dr. Javed here? Javed, are you there?
Yes, sir.
Yes.
Very good evening.
Dr. Khaja Javed is going to be presenting a quick case report on a patient with a similar pathology. Dr. Javed.
Yes, sir.
You can share your screen now.
Yes, I'm sharing my screen. Is my screen visible, sir?
Yes, it's visible.
Yeah.
A very good evening to one and all. It is a real honor for me for doing this case presentation. So without further delay, I will be starting off with my case. Shall I start, sir? Can I start?
Yes, please. Yes.
Yes. So, okay, first off with the history. A 63-year-old male patient presented to our outpatient department with the chief complaints of headache associated with neck pain since the past 4 years. In the history of present illness, the patient complained of headache which started in the neck region and spread to the front till the eyes, almost the upper part of the eyeball, and to the sides of the head region as well. The pain started in the neck region and radiated mainly towards both sides of the head. The pain also sometimes radiated towards the shoulder and the arm region on both the sides, but was not associated significantly with tingling or numbness. The headache is moderate to severe in intensity and dull or nagging in character, but non-throbbing. Initially, the headache started off as attacks lasting for 1 to 2 hours daily, occurring almost 4 to 5 times a week. Then it gradually increased to almost 4 to 5 hours almost every day. There is a history of limitation in movements of the neck as well. The pain aggravates on neck movement, especially on bending the neck backwards and on turning the head towards one or the other sides. The pain also aggravates on applying pressure over the back of the head and the neck region. The patient feels better after taking rest, resting his neck, not moving his neck, and with a few medications. There is a history of nausea and vomiting occasionally present whenever the patient gets the headache attacks. There is a history of occasional photophobia with headache, but it's not constant. Occasionally, sometimes the patient says he can feel tingling and numbness extending from the neck and up till the arms or the shoulder region. The patient is a truck driver by occupation since the past 25 years, and he used to drive for almost 6 to 8 hours for 5 to 6 days in a week since the past 25 years. There is no history of trauma or injury to the neck, no history of pain in the eye or cheek region, no history of redness of the eye or watering of the eye, no history of swelling of eyelids or the face, no history of nasal discharge or congestion. There is no history of triggers for the headache like loud noise, bright lights, etc. There is no history of dizziness or double vision. The numerical rating score is 8 on 10. Coming to the family history, there is no history of similar headaches in the family. Coming to the treatment history, the patient says that he takes tablet paracetamol 500 milligrams 1 SOS whenever he has the pain and gets the relief, but not that much. Coming to the medical history, the patient is a known case of hypertension since the past 10 years on tablet amlodipine 5 milligrams 1 OD. No history of diabetes or thyroid problems. Now, moving on to the examination part. On inspection, the skin is normal. There is no wasting of muscles or obvious deformity, no swelling, scars or ulcers. The shoulder symmetry is normal. Coming to palpation, There is paramedian tenderness present on both sides of the cervical spine. The cervical facet joints are tender. The trapezius muscle has trigger points. There is no palpable cervical lymph nodes or any thyroid swelling. Coming to the range of motion, there is a restriction of movement present, especially lateral bending and extension are limited with pain. Coming to the special tests, Jackson's compression test is positive. The Sperling's maneuver is negative. Shoulder abduction or relief sign is negative. Neck distraction test is negative. Valsalva test is also negative. Hermit sign negative. Adson's maneuver and the grip release test are all negative. Moving ahead to the neurological examination, coming to the higher mental functions, the memory, concentration, speech, orientation are all normal. Coming to the cranial nerve examination, the first nerve, there is normal smell sensation. Coming to the second cranial nerve, pupil size, shape, symmetry is normal. Visual acuity is normal. Coming to the third, fourth, and sixth cranial nerves, ocular movements are normal. Pupillary light reflex is also normal. Coming to the fifth cranial nerve, forehead and cheek sensations are normal. Muscles of mastication, motor power is adequate. The corneal reflex is normal. The jaw jerk is normal. Coming to the seventh cranial nerve, the facial movements are normal. The eighth cranial nerve, the hearing is normal. Ninth and 10th cranial nerve, gag reflex is normal. Coming to the spinal accessory nerve, shoulder shrug is normal. Turning head from side to side is normal. Coming to the hypoglossal nerve, the tongue movements are normal. Coming to the sensory examination, they're all within normal limits. Motor examination, the muscles are normal. Grade is 5 on 5. Coming to the reflexes, the biceps reflex is intact. Supination reflex is intact. Triceps reflex is intact. Babinski's test is negative. Knee reflex is intact. Ankle reflex is also intact. Coming to the systemic examination, the cardiovascular system, first and second heart sounds are heard, no murmurs present. Respiratory system, normal vesicular breath sounds are heard. The abdomen is soft, no evidence of organomegaly. Coming to the investigations which were done, the complete blood count is within normal limits. The patient had already visited a number of doctors before, and he had an MRI already with him. So this is the MRI films picture, which is
Javed, we'll sort of just withhold now before we proceed.
yes, sir.
The panelist, I know Professor McGeely is here, Praveen is here, Dr. Das is here. Who else is there among the panelists? Dr. Pankaj Surange, you're there? Dr. Palak Mehta?
I'm there, Karthik.
Okay. Dr. Chinmay Roy? Dr. Jebjyoti Datta? Okay, right. Okay, so can I start with, let's say, Praveen, Dr. Praveen Thomas? From the history, what does it sound like to you? This is just for the sake of the junior pain physicians. I just want to sort of imply how, as a senior physician, you will systematically rule out pathologies and come to a conclusion. The whole exercise is for the junior pain physicians. Keeping that in mind, at this point of time, having heard the history, what does it sound like, Praveen?
Okay. So before I thought I'll just give some visuals also, because I got the case actually. Thanks, Dr. Das actually sent it to me. So what I thought is that I'll just, along with that kind of an approach to how exactly I would go about it in terms of as a headache neurologist, I'll just share my screen here, if you don't mind. Okay. So, yeah. So this is a very, I thank Dr. Khan for choosing this case. It's really a pleasure to know that you chose a case which has got a lot of learning points.
And another thing I'll be telling Praveen, that it is a very common type of cases we very frequently get in the clinics.
Absolutely, sir. Absolutely. Now, the first thing, I mean, starting with the history, which Dr. Khan said, it started in the neck and spread to the front till the eyes and to the sides of the head. What I would be interested in knowing is the timeline of that spread. If it's spread over seconds, the first thing which comes to me is a neuralgic sort of a pain. On the other hand, if it is over hours, I would think about any other headache. It could be one of the primary headaches, could be migraine, could be tension type, it could be one of the secondary headaches. So one of the things about, I'd like to actually mention about this greater occipital neuralgic pains, which are short duration pains, starting from the occipital region on one side, depending on which nerve is affected. It goes shooting all the way to the front of the head and behind the eye in most cases, but we also do come across patients who have just pain behind the eye and the frontal region without any pain from the occipital region. Now the question is, how do you approach that in that case? You would possibly need to do some examination, just like you have Tinel sign in carpal tunnel, you also have Tinel sign in greater occipital neuralgia, and that reproduces the pain. The other question which you put, I mean, the other point which you put across is, sometimes it radiates to the shoulder and to the arm region on both sides. Now, what I really want to know is, what are the precipitants of this sort of a pain? Now, if there is a neck movement with radiation, I would think about a radiculopathy. But what is more important for me is the pattern. If there's a pattern which involves the neck, shoulder, and the neck, in the form of what is called as a coat hanger headache. So if you look at the coat hanger, you have the vertical bit is that it's like this. So imagine this is the neck. And then you have the two shoulders here. And then you have the upper thoracic region. So that bit of pain is typically described in intracranial hypotension causing headaches. So that's something which I would look out to when it comes to radiation to the shoulder and arm region, which is a very common complaint. Now, you said that the pain aggravates on neck movement, especially on bending the neck backwards and on turning the neck to one side. Now, the question is, if you want to add some specificities, is it backwards and then turning together? Is it on one side or on both sides? Now, if you're looking at a backwards and a shift, you're basically loading the facet joint, the cervical facet joint. And you also noted that the pain aggravates on applying pressure over the back of the head and neck region. So where exactly is the pain? So that's the importance of this is basically in mapping. So if you do a mapping based on the history, and then you map based on your examination and try to look for some sort of a link between that map which you got on the history, where you just give a paper and pen to the patient and ask them, give a very, very brief, cartoon of head, body, and neck, ask them to point where exactly it is. And then you examine the patient and you create your own map. You have a patient map and you have your own map. Now, I'll tell you one interesting thing about this test, these clinical examination tests like Sperling's or other tests, the kind of tenderness that we elicit by doing Jackson's compressive maneuver, etc. So Sperling's test was thought to be very sensitive. In fact, it's got a high specificity, but rather poor sensitivity. But when they correlated that with electrodiagnostic testing, there was only a 30% sensitivity of the Sperling's test. So when you say paramedian tenderness, you can map that out. When you say cervical facet joint tender, you can specifically mention which facet joint, and you can also map out the trapezius muscle trigger points. So just what I'm trying to say is this is one way of basically mapping out and getting more information before you to diagnose based on just the history, remember. Now, you also noted in your history I think, have we reached the stage? Because I just sort of create, there's just a few more slides that I have. I have kind of gone through what Dr. Khan has actually made us aware that what was done for the patient is that the cervical facet joints were visualized under fluoroscopy, and a bilateral C4, C5 facet joint had maximum tenderness and palpation. So before fluoroscopy, there was an attempt to kind of localize it clinically, that C4-5. Now, what is also important at that point is to look for reproducibility of the pain. And we all do that. I mean, as interventional pain specialists, we do that. We ask them, is it the same pain that you're having? Well, fair enough. But if there is no reproducibility, then think about more than one diagnosis. Right? So you should have reproducibility in the symptoms, at least one of the symptoms that the patient has come with to you with. Now, when you say that a diagnostic cervical medial branch block was done bilateral C4-5 facet joints with 0.3 ml of lignocaine 1%, what I would still not diagnose facetal arthropathy despite the clinical syndrome here of tenderness elicited and that of a diagnostic block. Why? Because unless I'm able to explain every other symptom of this patient, I would not give importance. It could be that, but I'll keep my options open. Now, one of the things, the reason why there could be false positives is that the inaccurate diagnostic blocks is because of this inadvertent extravasation of the injectate into adjacent pain generating structures. So there was a study by, I think it's Stephen Cohen, 2010 study, where he studied 24 patients who had the cervical medial branch block done. 16 patients had aberrant spreads, therefore creating a false positive result. Now, what do we do as pain physicians and neurologists, as pain neurologists or headache neurologists? We hunt for a pain generator and an oscillator. Now, the reason why I'm bringing this concept of oscillator is that, so there may be more than one generator. And what we do is that we try to shoot each of them, isn't it? That's what we do. But there could be an oscillator, which is actually maintaining a network between the generators. And it's always important to also identify this network. It could be a neuronal network, but there's one oscillator which is driving the whole problem. Now let us see from the neck, if you see, for example, joints. There is the atlantoaxial joint, atlanto-occipital joint, the facet joints. Now, if you said there's a history with neck movements. If there's a history with pain with head nodding, it's more suggestive of an atlanto-occipital joint pain rather than atlantoaxial, historically. So you always ask for a history of sudden stopping of a moving vehicle. It could be even a motorbike, which most people do. I mean, most people drive. If you ask them for a history of trauma, they'll say, oh, no, I've never had a trauma. But how many of us, including us physicians who are actually riding a bike, would need to actually put a brake in some of our busy Indian roads? So it's very important to actually take the history, and it's so taken for granted. They might say, well, they may give a history, they may not. It's important to ask. Ligaments. Now, if you talk about the neck ligaments, it's very difficult to test. And the only indirect estimate is from the instability. So we have to do checks for instabilities, which basically are flexion extension X-rays or MRIs. We'll come to that in a bit. So the other structures obviously are muscles, which, as Brian had said, they could be trigger points in migraines. Now, what is an important thing is about the concept of primary and secondary. There's a lot of debate whether they exist, but the secondary trigger points are maintained or mediated by a central sensitization. So primarily, migraine need not produce a trigger point, but because of the central sensitization, produces a secondary trigger points. On the other hand, when it comes to a primary trigger point, it's because of a primary injury there, and because it was compromised, that muscle didn't function properly. And so for the secondary and tertiary synergistic muscles stepped in to provide the function, and therefore they became compromised secondarily. So, well, that may not be important, but then it's good to know. The other thing is when it comes to the examination, one of the things that we also tend to do as neurologists is to examine the limbs and the torso very well. But we don't really, we don't generally, unless in cases like this, we don't look at the simple examination as touch and temperature in the region, for instance, cervical and the neck region, because there are two entities that are important. One is a primary hyperalgesia, which is contributed by sensitization of the peripheral nerve endings. It's called peripheral sensitization. So if you have a primary injury in the neck region, and there's the sensitization of the peripheral nerve endings with a whole of chemical processes, that's peripheral sensitization, and you get a primary hyperalgesia. Now, the secondary hyperalgesia is due to changes in the spinal cord and the other higher brain areas, the central sensitization. So why is it important? Because these are generally found in a neuropathy rather than neuralgia. So as Dr. Brian was saying about trigeminal neuralgia versus neuropathy. So depending on one of the ways in which they say, how do you differentiate between a primary hyperalgesia and a secondary hyperalgesia, is that if you have a heat hyperalgesia and mechanical hyperalgesia, it's more likely to be a primary. So it's basically one of the ways of differentiating whether it's primarily a problem which started with an injury to the nervous structures there, or is it because of another process which caused a central sensitization. Other causes and relevant history in this case I would be asking is there a history suggestive of dissection? It's very unlikely for a 63-year-old man with a headache which is going on for the last 4 years to have dissection. But if it was an earlier presentation, I would ask for sudden neck movements, manipulations to neck, which is very common, chiropractics is very common. And on examination, I would specifically look for a partial Horner syndrome. And if there's a doubt, I would get an MR angiography. The other important entity, which we generally tend to miss, even as neurologists and as pain specialists, is the entity called spontaneous intracranial hypotensions. They present with neck pains and headaches. And although classically it's described as a postural headache with a pain which gets precipitated by upright position and relieved by laying position, this is a history which is lost in oblivion over years. And eventually you come across a patient with migrainous features and problems with memory. That's all you have. And then you need to suspect SIH, the patient's having significant neck pain. And as I said, the coat hanger distribution. It's because of the low CSF pressure that's causing a brain sag, which is actually stretching the dura, which is innervated by the cervical at the nerves, and therefore causing this sort of an occipital pain. Now, just for your information, spontaneous intracranial hypotensions are not just headaches. They can present with dementia, can present with Parkinsonism, ataxia, weakness, and even rarely with cerebral venous sinus thrombosis, stupor, and coma. Suspect that, get an MRI brain and spine with contrast venogram, because then you look for a CSF leak from the spine. The trauma could be so trivial, there need not be a trauma. They look for hypermobility syndromes and problem spinal instabilities, which can precipitate these kind of miniature ruptures, which causing leaks through the dura. So that's important. The other thing is about the temporomandibular joint. Now, although temporomandibular joint pains are typically in the region of the temporomandibular joint in the neck, I'm sorry, in the temporal region, and in your patients also, you have the temporal region pain. The TMJ pain may not be so significant after a while for some patients, especially when it goes into chronic. They don't chew much, they just be very rigid. But what they do present with is a back, shoulder, and neck pain because of a TMJ. How do you basically approach that? Examine the TMJ intraorally and externally. I'm almost going to just finish this, but let me tell you that 2 out of 5 people with temporal arteritis, as the 63-year-old gentleman we have to suspect, also develop a polymyalgia rheumatica. And this causes pain, stiffness, and inflammation in the muscles around the shoulders, neck, and hips. So it's important to rule out that condition as well. Very rarely you have indolent meningitis without any of those florid features like fever, presenting just with a neck pain and occipital region pain. And that's because of the innervation of the posterior fossa dura by the cervical nerves. And they can, as I said, present with frontal pains as well. And that's also the same case with posterior fossa lesions. It could be a small cyst, etc., which produces this kind of a thing. It's very important to also know about this. When you come across entities like this, you have a lot of questions here. Is it the greater occipital nerve? Is it the lesser occipital nerve? Is it the third occipital nerve? Now, let me give you a very simple way of differentiating. Closer to the midline is the region of innervation of the third occipital, or rather, the referral region of the C2-3 zygohypophyseal joint, right? And lateral to that, you have the lesser occipital nerve. And the farthest lateral, you have the greater occipital nerve. So if you were to have a suspicion of a greater occipital neuralgia or neuropathy, and then, or even a secondary phenomenon along with the primary headache, because as I said, in a given individual, you can have a fascicular arthropathy, you can have a greater occipital neuralgia, you can have a C2 neuralgia, I'll come to that. It's just like as pain specialists, it's not very unusual to find the same patient having L4-5 left-sided facetal arthropathy, L3-4 discogenic pain, right sacroiliac pain, all in the same region. Similarly, in this kind of patient, you can have multiple things. So if you don't get an answer, when you want to go for a block, look for efficacy and reproducibility, very importantly. And if you have a greater occipital nerve block, which is kind of not answered the question, but you have a strong suspicion because that's the region of the pain, you can go for a fluoroscopic guidance to do a C2 nerve block. Now, one of the important things about C2 neuralgia versus greater occipital neuralgia is in C2 neuralgia, you have prominent eye signs. For example, there could be redness, there could be tearing from the eye, almost like attack, not as severe as prominent as attack, but such patients also report, along with this sort of a distribution of cervical to frontal and ocular pain with some redness and tearing. So, and in fact, greater occipital neuralgia can also produce the same thing. You can have a red eye with watering. So it's important to differentiate. And if, as I said, the greater occipital nerve block doesn't reveal anything, go for a C2. A lateral atlantoaxial joint pain can also mimic this. So again, if you don't get an answer there, then you're looking at the lateral atlantoaxial joint if you have a unilateral pain. If it's a C2-3 joint pathology with referral pattern third occipital, you think about a third occipital nerve block. And the important question here is, how many such things how many blocks can you do? It's the same thing like a pain specialist is usually encounters if he takes the lower lumbar spine. As I said, you have on either sides, you have a facet joint, you have a disc in the middle, you have the medial branches, you have the nerve roots coming out, and then you have the larger joints on the sides. So sometimes it may be required to do step by step. And it's always better to go for an ultrasound guided because sometimes the nerve twigs are kind of in between the fascia. So although we do a lot of blind blocks, it's always better to have an ultrasound guided. And then if you have some signal changes, I've not seen the MRI, I mean, I couldn't see the MRI clearly, to be very honest. If there are signal changes of high quality MRI, but without any definite compression, always evaluate with dynamic MRI. So flexion and extension MRIs should be asked. So for the young physicians, whoever are practicing, starting off with a pain practice, this is something which I want to just drive in as learning curves. The most from this case, for instance, do a mapping historically and also examination-wise. Try to look for reproducibility. Always think of more than one possible diagnosis in the same individual. Although we apply the principle of parsimony and Occam's razor, sometimes that's not what you come across in real life. And there could be more than one etiology. It's very common in head and neck pains. And we probably come to a stage when we're thinking about functional anatomy and biomarkers in headache disorders. I mean, that's going to be the future, and it's already here, almost here. So we're going back, we're going away from the pain generator high and functional generator hypothesis to oscillators and networks and biomarkers, and identify them and targeting them. I believe I should stop here because there are so many other panelists who are waiting to talk. But I think this is basically my take on the case. Very well presented, Dr. Khan. Thank you.
Thank you, Praveen, for the elaborate answer. Can I ask Dr. Javed to go ahead with the MRI?
Yes.
Share your screen, please.
This is the MRI of the patient. This is the other view.
So he is a 63-year-old truck driver, right?
Yes, sir. Truck driver occupation.
There's a bit of everything here, right? There's a bit of disc, there's a bit of disc degeneration, there's a bit of disc herniation, there's a bit of facet arthritis there. Right, go on, Javed. Go on, and we'll come back to the MRI.
Yes.
Go on, finish your case, please.
Yes.
Just finish the investigation part of your case.
Yes. So in the investigations, the complete blood count was normal. The MRI, the patient, since he had already visited a few physicians before coming to our outpatient department, already had an MRI done with him. And these were the only two investigations which the patient had, sir.
Go on.
Yes. So then what was done is diagnostic block was planned for the patient. Since the patient had paramedian tenderness.
Is there any other investigation you're going to talk about, Javed? Can I know?
No, sir. These two were the only investigations.
Okay. Can I call on some of the other panelists, please? Dr. Palak Mehta, you're there?
Yes, Karthik, I'm there.
Praveen talked a bit about various differential diagnoses. We talked in elaborate about cervical facet arthropathy or whiplash sort of injury. We talked about greater occipital nerve neuralgia, third occipital nerve neuralgia, C2, C3 facet arthritis. You think this could be a cervical disc degeneration itself, not a herniation? The patient does not seem to be having any radicular symptoms. The neurology in the cervical nerve roots is normal. You think it could be a cervical disc disc degeneration?
So the cervical spine disc degenerative starts at very early age as such, but normally it is not symptomatic. So when you are loading spine with the backward bending, extension, and rotation, the pain is there is more provocation of the pain. So personally, my diagnosis going in more favor of, as Dr. Thomas said, cervical facet joint arthropathy. One more thing I would like to add, that is myofascial pain. So there were multiple trigger points was there in the trapezius muscle. I would consider the trapezitis or bilateral upper back myofascial muscle pain as my one of the diagnoses, apart from the disc degeneration. So personally, disc degeneration, I'm not a big fan of discogenic pain, and I don't see much cases of the discogenic pain as well. So disc degeneration per se, it won't be in the top priority on my diagnostic list. I would be putting it at the last.
Can I just add, Dr. Palak, thank you very much. You've made it very brilliantly clear. There is only one disc which has got some evidence of being contributory towards cervicogenic headaches, and that's the C23 disc, not any other. So if you collected all the evidence and then pulled on together, this is possibly the only thing which, if at all, but as you said, everything else doesn't fit in. But if someone asks the question, can a disc in the neck region contribute towards a cervicogenic headache? C23 disc is the one which has got maximum evidence.
Right. Thank you, guys. Thank you, Palak, and thank you, Praveen. Javed, can you put the MRIs again? Can you display the MRIs again? Let it be on, please.
Yes, sir. I'll do it.
Can I call in Brian here and ask him what does he think of the whole thing?
Of the whole thing. Well, to make some broad comments, it's difficult to follow Pravin, I have to say. That was rather encyclopedic in the differential. But I will make a comment that especially for the trainees and folks, that there's no question he has symptomatic neck disease and cervical spine disease. He has some reproducible symptoms on neck turning and intermittent radiating symptoms. But as a headache physician, you also want, he said he didn't have a history of headache. I would specifically ask questions like, occasionally in the past, did you ever get a mild or moderate headache, use over-the-counters? And in women, I would ask, and did you get headache as part of perimenstrually? Because you might be able to bring out a migrainous tendency when just a screening question you wouldn't. If one drink of alcohol can give them headache and they avoid it, migrainous genes. And the reason why that's important is by the history here, occasionally, if you notice that in the history, occasionally there were more migrainous features, even I think nausea, vomiting, or throbbing, light sensitivity. Once you mount those associated features, you're mounting a headache, and often that is triggered by is cervicogenic, is triggered by neck pain. But if you have a tendency to primary headache, that tends to happen more. Now, whether that happens at all or not, it's still cervicogenic headache. But it's nice to be able to identify that. And also then you have to identify what's worse, the neck pain or the resultant headache. Here, it's the neck discomfort, and the neck is clearly still the driver. So separating out what's happening. I think that's a teaching point, and to be separated from all the migraineurs who also have neck pain. So migraine does not present at this age with headache anyway, fortunately. So the company the symptoms keep, the age of the person matters quite a bit. You see, if you saw somebody in their 20s who had some reduced range of movement of the neck, a lot of neck pain, it's more likely to be more muscular, just without facet joint problem, unless they've had an accident. So spine disease, as we get older, it gets more and more likely. In the young people, you really got to get a history of an accident or flexion extension injury to attribute causation to the actual spine, rather than just a lot of muscular, because there are a lot of migraineurs who have a lot of muscular neck pain. But the company that keeps here, this sounds like symptomatic spine disease, cervicogenic headache, and occasionally the headaches can be more migrainous. And that's just driven by the neck. I mean, those are some overall comments. I mean, there were excellent comments about not forgetting that CSF leak can present with stiff neck, neck pain, headache. It doesn't always have to be orthostatic. Fortunately, at least some of those times, you'll see telltale signs on MR imaging, especially if you use contrast. It's harder if you don't. So those are really important things not to miss. But it does appear to be more typical spine disease here. Now, there's relative preservation of the disc's heights. So this is not, and as we heard earlier, unlikely to be a primary disc problem driving it.
Right. Right, Brian. Thank you very much. Thank you for your inputs. Can I call in Dr. Pankaj Surange, please? Pankaj, are you there? Okay. Deb Jyoti, are you here? I can see you on screen.
Yes, I'm here actually.
Right. Thank you very much.
But the thing is, I'm not following properly. I'm really sorry. So I think I was just watching, but not following that much.
Okay. I thought you're not appropriately dressed, so you switched off the video.
Yes.
Right. Okay. So the question for you is: do you think this is more of could this be a occipital neuralgia per se, a greater or a lesser occipital neuralgia per se? We talked about facets, we talked about cervical disc degeneration, we talked about neurological causes. Could this be a occipital neuralgia?
The occipital neuralgia may be one cause of the headache, especially if it goes at the back of the head, and definitely there will be symptoms like tingling, numbness, and some neuropathic pain sensations will be remaining at the back. So that might be a differential diagnosis.
Okay. Okay, fine. If you are suspecting a cervicogenic headache, let's say caused by cervical facet arthropathy and vis-a-vis an occipital neuralgia, clinically, is there any way you can differentiate between the two?
So one of the things that can be clinically differentiated is definitely with the movements, because if it is originating from the cervical facet arthropathy, chance increase with the movement is usually higher. And if you press over the facet joints in case of facet arthropathy, there will be more pain, especially in the patients with the facet arthropathy. And in case of occipital neuralgia, I think the best way for this is going for the diagnostic blocks. So if you are putting a drug under USG over the C2 cervical spine and over the semispinal inferior oblique muscle and under this semispinalis, and you will be able to block the greater occipital nerve, then you are sure that whether it is occipital neuralgia or not.
But you could also say, if you don't get a good history of paroxysmal neuropathic shock-like history, which would be the proper description of occipital neuralgia, it's not occipital neuralgia.
Definitely, it may be a differential diagnosis, but we cannot say this is only by the symptoms. So when it is, the problem is that in some patients, the symptoms may be some deceptive. It may not be exactly saying. That's why the diagnostic box helps actually.
Can I just add a few points more? I mean, it's just probably adding on to what Brian just said. So the problem is whenever you come across a migraine symptom, there is a tendency to, if we ask the patient about, is it a throbbing headache? Yes, it's throbbing. Is there a photophobia? Is there a nausea? And then you want to say that it's got migraine features. And then you may come across this person with some early migraine features, but now presenting with a totally different headache diagnosis, as Brian said. But what I really want to emphasize in this meeting is, now, although it's probably useful to say that something has got a migrainous feature, when it comes to a given entity, it doesn't mean anything. Let me give you an example. Almost all the conditions which I just mentioned can have migrainous features. For example, spontaneous intracranial hypertensions, dissections, cervicogenic headaches. And it just means that the cervical and the trigeminals basically meet at one point, and all of them have got deeper connections in the brainstem and the hypothalamus, And it just means that migraine symptoms are an end stream effect of whatever primary pathology which drove a headache to begin with, which is why that's something which you come across in so many disorders. It's very important not to just kind of go along with that diagnosis and missing out the rest of the things because there are migraine symptoms. Migraine symptoms are just an end stream effect of many pain disorders.
Can I second that, Pravin? And it's part of the problem is we don't have a great nomenclature. For instance, if you have bacterial meningitis, you have migrainous features, light sensitivity, terrible headache, nausea, vomiting. With bacterial meningitis, these are non-specific, with the possible exception of certain aura symptoms, which are rather specific for migraine. Nothing else is. It's a final common pathway, but we don't have a good nomenclature for that. And we have varying propensities to trigger these associated features. Patients like this, some will not engage the final common pathway associated features. And so they won't generally be, they'll be able to continue on their daily activities. They won't be light sensitivity, nausea, worsening with physical activity, aggravation by routine physical, the sort of migrainous features. And there I am again saying migrainous features, but they're really final common pathway headache features. We don't have a great nomenclature, do we? Another way of saying that.
No, we don't. Which is why we at WHS just going to revise the classification. Yeah. Interesting, yeah.
Okay, I think there's somebody talking, but not the microphone is muted.
Okay, Karthik, can't hear you.
Karthik, we didn't hear you at all. Your microphone was off.
I don't know what happened, Karthik.
We're not hearing you at all.
You try to reconnect. I used to share a similar case. You know, many of you who came here at Darodia, Probin, Karthik, you all has seen her. She was the matron of Charnock Hospital. Uruleka Chakraborty, you must remember her. So very recently, she's now people. Just 1 month back, 1.5 months back, she was having the terrible headache, occipital headache, but this was unilateral, sudden onset headache, 50 plus. So you have to always rule out the, you know, the red flags. She was also having the many migrainous features. Like it was unilateral, it was, you know, coming and lasting for some few hours. It was throbbing, phonophobia. And I told her to do the MRI because, you know, 50-year plus sudden onset headache. But what she told something like, he was telling, okay, if I am doing the MRI, I am believing that I am having the brain tumor. And if I am having a brain tumor, so people will be started sympathizing me. So I won't do MRI, don't do any, you know, MRI or any investigation. If you can do something, do it. Otherwise, I am going to die. So this was her version. I told, okay, let me examine you first. History-wise, it was looking like that, but no, pain was starting from the occipital area, and on examinations, two things actually was very striking. One was neck movement was aggravating the pain, and very localized the pain over the cervical facet joint, C2C3 facet joint. And when I was pressing the pain was basically, you know, was reproduced, similar kind of pain was reproduced. So I told, okay, let me try, and I did the, you know, the medial branch block, and the pain was with just local anesthetic. I told, okay, this is a diagnostic block. I used to repeat the diagnostic block once again. Most likely your pain will be coming back, and when your pain will be coming back, I used to repeat it, and then I'll be going for the RF. This was my plan. But the fortunate part was after the diagnostic block, pain was relieved, and it never came back, at least for last 1.5 months. Still, I told, okay, you know, we should be having an MRI because you are 50 plus. But you know what I wanted to tell, like, you know, Brian and the Pravin, that sometimes, the features was like a migrainous features. If you are looking about the category classification of the, many of the features was like the features of the migraine. So it is not uncommon that this kind of patients might be their confusing one.
Absolutely. Absolutely.
Karthik, are you back?
Can you hear me now?
Yes,
Yes.
you can hear you now.
Just now.
Thank you very much. Thank you very much. Okay, thank you all the panelists. Can I ask Javed to ask, how he went on with this patient? How did he proceed, Dr. Javed?
Dr. Javed, please unmute yourself.
Can I share my screen, sir?
Yeah, please.
So after looking at the investigations and the examination, the patient was planned for a diagnostic block. Since the patient had the maximal paramedian tenderness, the cervical facet joints, he had tenderness. So the cervical facet joints were visualized under fluoroscopy. And on examination, bilateral C4-5 facet joints had maximum tenderness on palpation. So diagnostic cervical medial branch block of the bilateral C4-5 facet joint was planned with 0.3 ml lignocaine 1%, and it was done. So after the diagnostic block was done, the patient reported around 80% of pain relief. So these are the visuals. See, this block was done under fluoroscopic guidance. This is being seen over one side, AP and lateral views.
So his pain was unilateral, Javed?
Bilateral, sir. He had pain on both sides of the neck.
You have done the diagnostic block on one side.
Both the sides, sir. Both the sides, the diagnostic block was done.
So I saw one of your needles was on the articular process of C5. So you've done C4 and C5, is it?
C4 and C5, yes.
Right, and the patient had about 80% pain relief for the diagnostic block.
For the diagnostic blocks, yes.
Okay, that's fair enough. Coming back.
Can I ask Javed?
Yes.
So how long the pain relief was there? Pain returned back, came back again?
Sir, the pain returned back after 2 hours, sir.
Okay.
Okay, so you decided on C4, C5 level based on the facet degeneration in the transverse cut in the MRI. Is that it?
No, sir. On palpation also, sir. I had palpated the fascial joints under the fluoroscopic guidance as well. And since there was maximum tenderness over C4-5 facet joint, I decided to do diagnostic block at the point of maximum tenderness.
Okay, so you did some sort of mapping there. So that's,
yes,
yeah, that's fair enough. And I'm assuming for this patient, you have actually done the hematology workup, and obviously there was nothing else missing in terms of any inflammatory disease, and
yes,
you've done the hematology workup, and also conservative management was tried, and only then you went in for the intervention.
Yes, sir. Yes, sir.
Right. I think we are pretty much.
Karthik, can I comment?
Yeah, please.
So I'll be telling what Dr. Praveen told earlier, that many a times this kind of block can be false positive. In fact, in my certain cases, I have seen that the diagnostic block was positive, and ultimately when we did the radiofrequency very nicely, but still permanent results were not there. So one of the reasons, what Dr. Praveen already mentioned there, this is my personal experience. Diagnostic block was so beautiful, and after that, so some actually I saw the question in the chat box that what is the reproducibility. Basically, the dual diagnostic block is ideally to be done to see that, okay, we are repeating it and we are able to, see that the patient is having the similar kind of pain relief. But practically it is very difficult. Many times it is very difficult to convince the patient to do the diagnostic block 2 times. But definitely false positive is one of the very important things to consider. And second important thing is, if the drug is spreading to the adjacent structures, what Dr. Praveen told, the most important thing is your muscles, local muscles. If the myofascial pain is one of the reason, and your local anesthetic block, if it is spreading along there, some of the ligaments and other structures are there which is spreading. So all these are the possibilities. And as I told you, my case, I was not sure about the cervical facet in my case. Just now I told about the sister, because I injected there, hoping that I have done the medial branch block, but I'm not sure whether it was, it has spilled to the muscles, whether it has become, and the pain was gone for gone. Ideally, theoretically at least, if it is facet joint, the pain relief should be matching with the duration of the local anesthetic, and you are going to reproduce it again, and with the longer acting local anesthetic, then only you can confirm it. So, in this case also, the diagnosis was not 100% sure that it was coming from the facet joint. So same thing here, I used to mention here to Javed, that it is most likely cervicogenic headache, most likely it is facet, but still we cannot be sure about it, and we have to rule out the other possibilities. And the most important possibility is where it is spilling, whether it is really a false positive, whether we are whether we should do the second time block with a longer acting local anesthetic. All these things should be considered.
So one more, can I just add on what you said is, when it comes to this, there's this map of distribution in pain in patients who had controlled diagnostic blocks and the relief of the pain in the head with that. There is this beautiful study by Bob Duke, which is published in the Oxford textbook. None of them had C4-5 blocks which relieved their cervicogenic headaches. It was always either C1-2, C2-3, or C3-C4. I mean, if you have a coexisting facetal arthropathy and you elicited a tenderness there and you gave a block there, the pain may go, yes, and then come back. But that may not be the cause for the cervicogenic headache. As you rightly said, it has to be probably higher up. That would be the ones which fit into the criteria of what we call as cervicogenic headaches. Otherwise, it may not. In your case, in the patient, in the nurse, she had clinical evidence, isn't it? So you did the right thing by going ahead with that, and therefore she had a wonderful response. Thank you.
Right, thank you. If there is any doubts to any of the panelists or anything else, anybody wants to contribute, this is the time. Somebody would like to ask, maybe you can take the question, Javed. How do you identify the local anesthetic, the medicine that you give is not leaking to one level above and below? And would you like to add a contrast if required? Or what volume of local anesthetic you gave in each level?
0.3.
Sir, volume used was 0.3 ml, sir, at each level.
Yeah, I think that Dr. Supio Gupta has asked this question. So I think if you are injecting 0.2 or 0.3 ml for a diagnostic medial branch block in the cervical segment, that should take care of not having any spill. So if you want to be really accurate, you can also put in an RF needle in the first place, do a stimulation, and then do a diagnostic block. That makes it a little bit more accurate. And again, just to add on, if the diagnostic block is negative, it could be a few things. It could be that the pain is not coming from the facet, it is the wrong level, or it could be the wrong side. So all of these possibilities you have to keep in mind if it's a negative diagnosis. Right. Anything else any of the panelists would like to add on, considering this is a young group of pain physicians, as like an advice to them in terms of having the right approach to patients with neck pain and pain in the head?
Well, I would just like to add what's maybe very commonly experience that there may or may not be articular disease in somebody with bad neck pain. It may so they generally have some degree of muscular pain and spasm, and there may or may not be a focus in the spine. In the young people, it tends to be not as much a focus in the spine, but just muscular. And as we get older, there tends to be more of foci of pain in the spine itself. But my point I wanted to make is there seems to be a variable amount of reactionary muscle spasm around these sites. So although there may be just a site at C4-5, the amount of muscular spasm can spread and make it difficult or impossible to identify what is going on. So you can have a variable amount of muscular pain that can encompass many levels from just one focus, in my experience.
Right. Point well taken, Brian. Anything else? Anybody else wants to add? Right. On behalf of Dr. Das and the Daradia Pain School, so I would like to thank all of you guys. Dr. Brian McKinney for joining us all the way from the US, Dr. Praveen Thomas. It's been a pleasure having you, and I'm sure all the young pain physicians from India, we had at one point, the attendance was around 100, I think. So a lot of them attended the show, and the recording of this is going to be available for future reference as well. So thank you very much for joining us. In terms of the panelists, I would like to thank Dr. Palak Mehta, Dr. Debjyoti, who joined us. So thank you very much. So the take-home point for the young pain physicians is, remember, it's a multidisciplinary game. There is no way as one specialist in terms of being only a pain physician, we may be able to solve any of these problems. So remember that a lot of these things which when Praveen was talking about are things that normally as a pain physician may not occur to us. Like today he talked about the CSF pressure being low, and that can cause neck pain. He talked about coat collar syndrome. So these are things probably only the mindset of the neurologist can pick up, and not a typical outlook of a pain physician. So remember that this is a multidisciplinary game, and don't hesitate to take the help of your colleague when you're dealing with situations which you don't fully comprehend. So remember that teamwork always does better. And in terms of case report, I think a systematic approach would be what you should keep in mind. In terms of doing a good history and clinical examination and having a few differential diagnoses in your mind, and then confirming that with your hematological and radiological assessment. And if both of these are sort of matching, you can go ahead and treat these patients. One. And second is, Javed didn't cover too much detail about hematology. So in terms of blood tests, there are a few things which we should be absolutely clear about in terms of any other inflammatory diseases, vitamin deficiencies, uric acid, hyperuricemia, all those things have to be ruled out before you do this. And again, treating these patients, conservative treatment should be given priority, and you should as well work on his occupation. So if it's going to be a patient who's having neck pain, and after you sort him out, and if he's going to go back and do truck driving in the Indian road, I don't think he's ever going to go to settle. So in terms of occupation, maybe you should advise him on maybe looking at a desk job or something like that. So that's something that you should work with. And after you do the procedure, whatever procedure you're planning, post-procedure, cervical stretch, strengthening exercises, occupational therapy, rehab, and like Brian was saying, if there is associated muscle spasm trigger points, those are things that you should take care of as well after you do the facet block. So keep all of this in mind. A systematic approach always helps. And when it comes to cervical and head and neck, don't get too aggressive in terms of treatment, because a lot of these procedures are quite ablative. Blocking a nerve with RF ablation can cause side effects. So word of caution there. So if you're a young pain physician, my emphasis would be on doing the lumbar and the sacral procedures first. And once you're comfortable with that, think of procedures in the cervical and the trigeminals and the spinopalatines and the glossopharyngeal. So these are slightly advanced procedures. Only once you're comfortable with the basic procedures, the lumbars and the sacrals, you should do these procedures. So I hope we have sort of, as a group, given you a sort of guideline to treat midfacial pain and cervical pain and headache. Keep the website that Praveen Thomas mentioned in terms of the Headache Society that's formed. And those of you who are interested in more education and more research and more training in terms of headache can look up at the website and take it further from there. So on behalf of all the panelists, thank you for joining us, and stay safe. Thank you very much.
Thank you.
Thank you, Karthik, for very nice moderation. Thank you, Brian. Thank you, Praveen. Thank you, Javed. So even in the COVID situation, many of us here are very much depressed, and many couldn't join because of the duties in the COVID ward, as well as busy with their near and dear one. So it's a very grave situation in India, and we all have to remain safe. And still, in spite of that, many people joined, and we had a very good academic discussion. So thank you all. Thank you all the participants, attendees also, for joining this program. Thank you very much.
So much for organizing, sir. It was amazing. Thank you so much. Thanks. Thanks for inviting. Thanks, Karthik, for wonderfully moderating. Thanks, everyone.
Thank you. Thank you.
Take care. Bye-bye.
Thank you. Good night. Bye-bye.
Stay safe and take care of everyone.
Thank you, sir. Good night.
Remembering everyone in prayers. Stay safe. Bye-bye.
Okay, Kamlesh, we can end the meeting here. Hello, Kamlesh, Vikas.
Sir, you are on mute, sir.
Yeah,
Please
yeah.
unmute yourself.
Sorry. I'm really sorry. So I was just sharing. Thanks a lot, sir, for allowing us to be a scientific partner for academic activities. It's an honor and privilege. So actually, I'm hearing Dr. Karthik Natarajan sir for first time. So it is very impressive. Even most of the speakers I heard first time. So very impressive, sir. One request, sir, please allow other programs also if you are planning. And we have discussed also, like we can move for low back pain or maybe
Right.
So
right.
I will talk to you. I will schedule it. So recording has been done, sir. I will submit.
Yes. It will be very nice if you can distribute the recordings to the participants who joined, and even those who couldn't join, them also can say. They
Sure.
can also learn by record by hearing these things.
Sure, sir. Sure. Thank you.
Thank you, Johnson. I should have probably given you a chance to talk. Sorry. Thank you.
No, it's okay, sir. Vikas,
Thank
can you?
Yes, thank you so much. Thank you so much, Dr. Gautam, and thank you so much all the speakers for giving us this opportunity to collaborate with such an esteemed organization. And we'll definitely, sir, we'll be looking into many more such collaborative events, sir. And as Kamlesh already told, sir, anything related to low back pain or osteoarthritis pain or palliative care or anything related to pain, migraine, but I think we are always there, sir, to collaborate and disburse the medical education amongst all the HCPs, sir. So please do.
Right. I talked with Kamalesh, so a few more this kind of sessions will be coming in future.
Thank you so much, sir.
Thank you.
Okay.
Thank you so much, sir. Please take care and your family as well, sir, in this crisis situation.
Right.
Thank you so much.
Okay.
Good night.
So
good night, sir. Good night all.
Okay. Good night.
Good night.
Good night, sir.